Okay, we're going to get started. Thank you, everyone, for coming, for spending your evening with us to approach this very important topic to all of us in this community. For those of you who don't know me, I'm Mike Cassady. I'm the Brattleboro Fire Chief. Welcome to the Brattleboro Fire Department, and welcome to our community open forum on opiates. We're glad that you're here, and we hope that this is going to be a very informative night. We've got a great panel put together, and then our plan is to open it up to the floor to answer your questions and hear your concerns. We did not expect this turnout, so don't tell the fire department that we're over capacity. One big thank you before I get going. I'd like to thank Taylor Wellington, who is the Director of Emergency Services at BMH. She partnered with me to put this together and to make it a reality, so thank you, Taylor. Couple of house cleaning things before we get going. If there's an emergency in this building, there's an exit door here to the front of the room, and there's an exit door where you came in. Bathrooms, there's one in this hallway right behind this wall. There's a hallway there with a bathroom, or down at the foot of the stairs in the lobby where you came in, there's another one down there. And please help yourself to snacks. There's water, coffee, cookies, donuts, everything that will help you with your diet. So in 2018, 110 Vermonters died from an opiate overdose. 21 of those were in Windham County and 7 right here in Brattleboro. And we've already recorded 2 deaths in 2019 locally. As you can see from the information on the board, the numbers continue to rise with each passing year, and there's no end in sight. Only through the joint efforts of all the agencies and services represented here tonight will we begin to even slow this crisis and what has been described nationwide as a health crisis. So just a quick review of how the evening's going to go. Very shortly here, I'm going to turn it over to Gina Patterson, who is the Director of Development and Marketing at BMH. She's going to be our moderator for the evening. She's going to direct traffic and keep people moving along so we can get everything in the 2 hours we've scheduled this. If it gets too hot in here, let me know, and I'll turn the air conditioner down even lower. Okay. So with that, we've got a couple of opening statements from the town manager and the chief medical officer from BMH. Then we're going to move on to the panel, and each member of the panel is going to give a short presentation on their agency and what they're doing to help with the crisis in this community. And then we're going to open it up to the floor for you folks to participate. So with that, I'd like to turn it over to Gina. Thank you.
Thank you, Chief Cassady. So first, I'm going to just establish a few ground rules here. Mostly remind everyone that we're all here for the same reason. We want to hear from the organizations in our community about what's being done related to the opiate epidemic, and to hear questions, concerns, and suggestions from all of you in the audience. It's important that we remain respectful to each other. This is not a time to blame anyone or any organization. It's a time to hear concerns, talk about the concerns, and maybe hear some suggestions. So as Chief Cassady said, I'm going to introduce in just a moment the panel. I'd like them to go through and give just a brief overview of their organization and what they're doing here in our community. We will have time for questions and answers at the end, so please don't, we won't ask questions during that time. We'll let them do their spiel and then have questions after that. So to kick us off here, and then I'll be back to introduce the panel. First, I'd like to introduce the town manager, Peter Elwell, and the chief medical officer, Dr. Kat McGraw from Brattleboro Memorial Hospital.
Good evening, everyone. It is overwhelming to see you. It's both really exciting and really sad to have this amazing of a turnout to come together as a community around this topic. The statistics that are on the board up there indicate the way that this crisis has become more present in all of our lives and better known to all of us, even though it has been escalating over a long period of time. And for the experts on the panel and for others in our community, it's been an ongoing situation for longer than some others of us maybe have perceived. But there is no doubt that it is now something that is affecting everyone in Brattleboro, one way or another. And so from the town of Brattleboro's, from the town government's perspective, in these years when it has been growing worse, it's been the police department and the fire department that have been primarily experiencing this within our town government. There were the folks on the front line. The police department in dealing with both the law enforcement aspect of this and the drug trade that makes it possible, and also increasingly and significantly in the social service aspect of it, working together with colleagues that are on this panel and others in the community to make sure that we're providing service in the community around these issues in ways that go far beyond traditional law enforcement. Project CARE is the most significant, most visible aspect of that, but there are other things that we'll hear from Lieutenant Petlock about as this evening goes on. And one thing that we in town administration and the select board have realized is the necessity of getting more information out into the community. And so while those services go on with the police department's activity, with the life-saving work that the fire department does in treating people who are plagued by this disease, we know that public information has become, critically important for us. Opportunities to come together like this and learn and explore ways in which together as a community we can address this plague and make it better. So again, just thanks to every one of you for showing up. We were hoping for maybe a couple of dozen, if it didn't rain, maybe 40 or 50. It's really amazing to see all of you here, and thank you for being part of this.
I also want to say thank you and welcome to everybody here, my neighbors, my patients, my friends. And this is such an important issue in our community, and this turnout really reflects that. And I also want to say thank you to everybody here on the panel, many of whom I know well, for taking the time and wanting to talk to you about what they know and what they do every day, and their concerns for these issues in our community. So I want to start with just a quick show of hands.
Before we begin, is it possible that we can address the fact that there are many, many concerned people here who can't be in the room? Wow. Is there any way we could reconfigure things so that everybody can be in the room who wants to be?
Give it a shot. We're out of chair.
Standing back in that corner.
Yeah.
Sit on the floor here.
Yeah.
Oh.
You guys move back. Yeah, you can move that table.
Oh, yeah. All right. How many people can sit on the floor up here in the corner here? I want to tell them they can come and sit on the floor.
There's a little room up here for people to sit on the floor. Up here by the front. Oh, wow. A few people can come up here to the front corner here, and there's a little bit more room up here as well. Wow. Yeah. There's room still here up in the front if somebody wants to come over here. Okay, you can, if you want to hang on to my stuff, then it's fine. Somebody else can take that. Yeah. Somebody want to give a hand signal back there when the hallway is emptied out?
Sit, stand, whatever you want. No, you're fine.
Okay.
I think there's still room up front too, if there's anybody who can make it that way.
We have one chair for someone who needs to sit in a chair.
Lots of space up here.
There's one up front here.
There's still some space if somebody wants to sit on the floor up here. Okay, all right. Thank you. Wow. So I was going to start with a show of hands and just ask, how many people here in the room know somebody touched personally by the opiate crisis? Yeah. Okay. And how many of you have tried to help? Right. How many of you check Facebook or Instagram to see if there's somebody out there who's still actively posting and they're still around? Okay. How many carry Narcan in their pocketbooks or their pockets? Yeah. And think back to the first time that you were aware of somebody you know overdosing. Was it last year? Was it 5 years ago? 45 years ago? This is not a new issue. This is something we've been dealing with for a long time. But as you can see by the numbers that the chief talked about, it's ravaging our community in an increasing pace. So thank you all for being here. At Brattleboro Memorial Hospital, we're in a little bit of an interesting position in that we sit on two sides of this issue. We treat patients with powerful opiate medications, and we treat overdoses every day. And that's an interesting paradox and a difficult position to be in. It makes us need to be very proactive about this issue and be very responsible in the way that we're acting. So I just want to touch on a few things about that. And the folks here have great depth of knowledge about it. But there are a few things that we've done at the hospital that I want people to be aware of. To start with, 2 years ago, the legislature passed a law that means that every time that a physician or a nurse practitioner or a PA wants to prescribe a patient an opiate, they actually need to check an online register. And that register lets us see, as physicians, see whether or not the patient we're about to make a prescription for is in fact filling prescriptions in other places as well. It gives us an eyes open view of what that baseline situation is for that patient, so that we can know that we are not feeding into somebody who is needing to go prescription shopping, as it were, to get opiate medications. We give educational materials, we do counseling, we do a risk-benefit analysis with each patient before deciding whether they truly need to have those prescriptions. This past year also, we started an opioid task force, and in fact, there are a few people here in the room who are members of that. It's comprised of doctors and nurse practitioners who review the prescriptions that are being given to our patients from our medical group to ensure that we are trying to give the safest dosing possible for those medications, to bring down those very high dose level medication prescriptions and work with clinicians to bring them down, to work to try to taper patients off of those medications where possible. And then lastly, we know because when we give prescriptions, sometimes people don't need all those pills, so we put some boxes in the front of our hospital so that people can come in and securely and safely dispose of their medications. It can be the hypertension medications they don't take anymore, or it can be the extra Percocet pill that they don't actually need. And that's, all those things are things that we do on the proactive prescribing side of things. But we also work very deeply on the other side of the coin in terms of worrying about the treatment for opioid overdoses in our community as well. And these are the folks who are very involved in that side of the coin, and they'll talk more about it as we go on. But a couple of quick highlights about that. One is last year, the Department of Health for state of Vermont wrote standing orders for Narcan, which is possibly in part why many of you do have Narcan in your pocketbooks. And the standing orders means that you can go into any pharmacy and get Narcan without a prescription. And Narcan is for those of you who don't know, Narcan is the nasal spray drug that you can give somebody who's overdosed that can be life-saving treatment for them. And just yesterday, I had my wife spot check this to see if it was really, really true that she was going to be able to do it. She went into the pharmacy to get that, and yes, in fact, they would have given her that Narcan. If the insurance didn't pay for it, though, it would cost $100. So at BMH, we have started partnering with the state and providing Narcan for free from our emergency department for people who think that they or their family or their friends might need a dose of it. It's an important part of yeah. And our most recent initiative has to do with medication-assisted treatment, which I am quite sure you'll hear quite a bit more about tonight. But we have begun putting together pieces to pilot a program this summer to be able to start treatment directly from our ED. So before people even leave the hospital, they can come to the emergency department to get medication-assisted opioid treatment started for them and we're doing it in conjunction with the retreat and all the other partners involved in this process. So we look forward to that this summer as well. So a friend of mine who I don't think is here tonight said to me when she heard I was coming here, she said, the challenge of how to help or even help solve this just really feels out of reach. But I can recognize that might feel this way right now, but when I look around the room and see, oh my gosh, how many people are here, and the amount of effort that goes into the day-to-day work for folks here, and the amount of work that's really going on across the country. If you Google opioid treatment recommendations, I think you get 48 million hits, 48 million, right? It's just a phenomenal thing, right? So I think that we are on the journey to recovery. And as anybody in the community can tell you, that's a long journey and it's a tough one, but I think we're actually working our way there. So thank you for the fire department for hosting this and for everybody up here and everybody here, and I really look forward to a robust discussion tonight.
Thank you, Dr. McGraw and Peter. Appreciate that. So to start with the panel, I'm not going to introduce each person, so if you all will introduce yourselves, say what organization you're with, and a few minutes about what you're doing in this community when it comes to the opiate epidemic, that would be great. So we'll start down at the end. Lieutenant Petlock.
Press the button. Sure.
Could they stand as well so folks can see them?
Well, it's hard with the microphone. That's the trouble with that. Sorry.
Yeah, so my name's Adam Petlock. I'm a lieutenant with the Brattleboro Police Department. I'll try to talk as fast as I can. I only have 5 minutes. So, basically Project CARE, which is Community Approach to Recovery and Engagement, it was developed as a way to reduce the impact the opiates were having on our community. And as we can see by the crowd that is here tonight, obviously it's having a huge impact on our community. What we were aiming to do is form this partnership with people, many of who are sitting right next to me, and just identify what the problem is, what the obstacles and barriers are, and what we can do, develop strategies to help solve the problem. So we got together with Turning Point, Groundworks, Habit Obco, the Retreat. Who am I forgetting? There's BMH. There's many different organizations we partnered with, and we've worked together and we've kind of developed some ways where we can be proactive in this effort. Part of what we've done is we've trained the officers. So officers all carry Narcan now. They're trained in how to use it. They're using it regularly and effectively. We've brought people in recovery, recovery coaches from Turning Point into the police department to train the officers, to talk about stigma, to talk about how this process works for people, to try to get into their shoes. And we visited treatment facilities, both inpatient and outpatient, not only the medication-assisted treatment facilities here in town, but also Valley Vista, Serenity House, the Retreat, just to develop better relationships with those programs and get people connected to quicker and more efficient treatment. And again, we're just trying to be proactive. We got a great grant from United Way of Windham County, which has enabled us to transport through Turning Point over 20 people to various treatment facilities. Those are people that would not have been able to get transported to those treatment facilities in that efficient a fashion if we didn't have that assistance. We've been going out and doing outreach, proactive outreach in the community, identifying where overdoses are occurring and who they're occurring to, who is at risk in the community, and who we need to get in and really outreach with and really get to. And we're utilizing the services of Turning Point and people that really have that lived experience, because they're much more effective than me in getting the point across. And finally, the enforcement that we do has to run parallel to the outreach efforts. We realized right at the beginning of this, and really a long time ago, that as has been mentioned prior to me talking, the police department is not going to solve this problem. We're not going to wrest our way out of this problem. There's no simple solution that the police department is just going to show up and end this. So what we need to do is be proactive. It's important that we parallel those efforts, and we've certainly ramped up all the efforts we can involving the Southern Vermont Drug Task Force, the state police, federal agencies, and we've done what we can to cut the product off and address those people that are coming in and victimizing people in our community. But we still have to be proactive in outreaching those people that are being affected and those people that are being victimized, and really thinking outside the box. So that's really what we're trying to do.
Great.
I said I'd keep it short.
Terrific. So I'd had a PowerPoint, but now I'm going to just go completely awry from that. So my name is Stephanie Thompson. I am a public health analyst with the New England High Intensity Drug Trafficking Area Program. A clear delineation is we're a program, we're not an agency. We're funded under the Office of National Drug Control Policy under the Executive Office of the President. So we have a congressional designation money that helps to fund our program. We're in all 50 states. The New England HIDA encompasses all 6 of our New England states. And primarily the focus of the HIDA program over the years has been to work with the drug task forces and law enforcement in different areas across the country in order to impact, and interdict drug trafficking organizations and try to dismantle some of that and eliminate some of the supply. Back in 2015, as particularly the northeastern part of the United States was really starting to see the impact of this opioid epidemic, a number of the HIDA directors got together and said, we need to be doing more than just looking at the enforcement side of this. As the lieutenant said, we can't police our way out of it. Everybody has to come together, and we need to look at this in a wraparound, holistic approach. So in 2015, it was 5 of the HIDAs set up at that time, it was the heroin response strategy. We've now transitioned from heroin response strategy to the opioid response strategy and now the overdose response strategy, as we continue to recognize that this isn't a single substance issue. It really is a polysubstance problem that we have, across our country. So we are now in 24 states. We are anticipating potentially bringing on another 6 this year, and we're hopeful that we will receive the congressional funding in order to make this a national program. A lot of our sister states are experiencing different challenges, from opioids to methamphetamine, crack cocaine. So trying to also work to monitor trends that are happening across our jurisdictions to try to get ahead of what the next challenge we might be facing are, and what the emerging threats are. So with the opioid or the overdose response strategy, in each state that's part of this, we have a public health analyst, which is myself, and a drug intelligence officer, which is James Downs. Many of you may have met him as well. So we're tasked with working to bridge the gap between for public safety and public health. trying to bring together those different worlds, the different schools of thought, looking at different data sets, how we can come at this from a variety of angles. It's about coordinating, data sharing, building relationships, collaborating, fostering the partnerships that exist in communities currently, working to bolster those where we can, and also to tie in the work that's happening in different areas of our state where there may be similar challenges or similar efforts underway. So really the main takeaway that I want to tell folks is myself and James are here to be a resource. We have a partnership with the Centers for Disease Control and Prevention, in addition to our 24-state network, as well as the connection with all of the other HIDAs across the country to reach out if people have questions or there are situations that maybe we haven't encountered here in Vermont. We have a large network of brilliant people that we can reach out to for guidance, assistance. We're able to help with research, data analysis, education, trainings. Pretty much if you have something that you think we could help with, throw it at us and we'll do our best and certainly try. And for me, I'm a Southern Vermonter, born and raised, so this part of the state is very important to me. And I commend all of you for being out here tonight. I know that this is a community that's been hit really hard and continues to be, but the panel here and the folks in the room, it just shows that there's a lot of people committed to working on this from all angles. So I thank you all for that.
So my name is Tracy Shriver. I'm the state's attorney here for Windham County, and I am here to affirm what Stephanie just said and what probably everybody in this room already knows. We can't arrest our way out of the problem. I represent what happens when people get arrested and charged. I'm here to represent the criminal justice system, a system that is strained, that is bulging at the seams, that is a little outdated, and trying its best to deal with everyone in the room who's there doesn't want to be there. The defendants don't want to be there. The people who've been victimized don't want to be there. And we're trying to deal with a surge like we haven't had before. Yes, we've had overdose problems, and yes, we've had substance abuse disorders, and yes, those have all fueled crime, but it has become an epidemic in the criminal justice system as well. And there are some ways that are working that we're trying to expand and change the way we deal with this problem, but we need more. We need more tools to do that. And by saying tools, I don't mean jail, because I don't think jail is going to help us out of this problem either. We're trying to do different things. We're trying to work with our Community Justice Center. We're trying to work with youth services here and try to do different programs with the police department to make sure that crimes are dealt with appropriately. And my system does not always deal with them appropriately. So I'm very happy that you're all here, and I'm happy to answer questions about what's going on and to tell you what we're trying to do. But if I don't say anything else this evening, although I doubt that's true since I'm a lawyer and I like to talk, I want to make sure everyone in this room knows that Vermont has a Good Samaritan law. And what that means is if you find someone or you know someone or you're with someone who's overdosing and you might be using as well, you can bring them to services. And you won't get in trouble, and they won't get in trouble. And that means not just, and it breaks my heart that I just learned that people didn't know this, that means not only getting arrested, it means if you're already on probation or parole or you're already on conditions of release, you won't get in trouble. So I'm happy to tell you more about the Good Samaritan law. Look it up. You can look it up online. But if you don't learn anything else tonight, please remember that.
Hi, I'm Taylor Wellington. I am the Director of Emergency Services for the Emergency Department in Brattleboro. This originally started as kind of a training session for first responders. Narcan administration, what to do if you see somebody who's overdosed, also kind of resources and about how we as first responders are also particularly susceptible to substance abuse. So we were sitting there talking about it, the chief and I, and he said, you know who should hear this is the community of Brattleboro. We're doing a lot of good work and the community is really concerned about this topic. We should let them know what all of the community is doing to help this problem. So nice job on the brainchild there, Chief. So Dr. McGraw has already mentioned that we will give free Narcan through the emergency department. You don't have to show up having an overdose. If you show up with your friend, you're concerned, we will be happy to work that out. We can manage that. Another initiative that we have started is we have collaborated with Turning Point to integrate recovery coaching into our department. So if someone comes in looking for treatment for their substance abuse disorder, it doesn't matter what it is, opioids, alcohol, nicotine, we will bring in a recovery coach to help that person work through those issues, come up with some strategies, make an appointment for follow-up, groups, the whole thing. They've been a really great piece of the puzzle for us in terms of recovery. We are also starting medication-assisted treatment soon, but I think my friend Matt's going to talk about that. So I'm just going to keep going down the panel. Thank you guys all for showing up tonight. It's a really great group.
Hello, my name is Nicole Dean. I am the nurse manager for the emergency department and the critical care team at Brattleboro Memorial Hospital. For all intents and purposes, I'm her second in command. I was invited to join the panel not specifically from the point of view of an emergency provider, but as the emergency department's subject matter expert in domestic and sexual violence and in human trafficking. So how that relates to the opioid crisis is that women who are not using, or men and women who are not using, are 1 in 6 are likely to be victims of sexual assault. That number doubles when a person is a victim of addiction. And so it's not just domestic violence or sexual violence, but it's also human trafficking, which when I say that, a lot of people go to this really Liam Neeson place in their head and start thinking about all of the special sets of skills, but it's not like that in southern Vermont. Yeah, I'll find you. It's not like that in southern Vermont. Human trafficking looks as simple as the teenage panhandler on the street who is using sex work as a way to feed their addiction. That is human trafficking in southern Vermont. And a lot of people often look around and they think Vermont, trees, sleds, maple syrup. You know, this very picturesque view, but I promise you it is happening here. It is something that is happening in our community. It is in front of us, looking us in the face, and it is a huge umbrella term. Human trafficking, by definition, is forced labor or sexual act by force, fraud, or coercion. And that is a huge umbrella. Almost anything can be force, fraud, and coercion. So we are looking it in the face every day as emergency providers, as law enforcement, as first responders, and as community members. So in the emergency department in particular, so how can we help, right? We are training our staff and we are training our first responders, both police, fire, and EMS alike, to recognize signs of human trafficking in the community. Are they seeing it? Can they identify it at first? And then what should they do? So the emergency department is a safe place. We will work as hard as we can to get you a private space to make a phone call to our wonderful partners from the Women's Freedom Center, who I think there's one in the back somewhere I saw.
I thought I saw Sherry.
Yeah.
Oh, there she is.
Hi, Sherry. We have a wonderful partnership with them. You can come to our department, you as a community member, if you are experiencing domestic sexual violence or human trafficking and you cannot get out of that situation on your own, come see me. They will call me at home. I will get you to the place where you can be safe. We will get you to the Women's Freedom Center. We will help. Please don't take it anymore. Come to us. We're here. So, Matt.
Good evening. Thank you all for showing up. I think about the heartbreaking statistics of Windham County and seeing that the numbers have been rising for overdose deaths, which has been different from the rest of our state. I know that there's work to do here, and what I would say is that I've seen a lot of the background work that's been happening, and what I'm most proud of are the community initiatives that couldn't be achieved without the willingness and the coordination of those on this panel. So thank you first to everyone that are making the efforts to make this community healthier, and we're doing it together. When I think about the statistics, these are not alternative facts. These are not misinformation. These are statistics. But beyond those statistics, these are people's lives, and we never lose sight of that. We are launching an initiative in the emergency department, and I'm the nurse practitioner in the emergency department, to meet those needs by starting medication-assisted treatment. And for all intensive purposes of this panel, when we talk about medication-assisted treatment, we talk about methadone and we talk about buprenorphine. Buprenorphine is probably what we'll focus on mostly tonight, but I wanted to just sort of clarify that and help you understand that this is a measure that we're taking that has been shown to and demonstrated to help people. We couldn't have done it without our key partnerships. I really want to draw attention to the extraordinary collaboration we've had with the Brattleboro Retreat in this measure. Their clinical expertise has been just renowned and wonderful, so thank you. Yeah, of course, sorry. So I just wanted to say thank you to the Retreat for that process. We talk about harm reduction with a lot of this, and we can get into that more as we move down. But I just want to emphasize right here, right now, that medication-assisted treatment reduces the opiate overdose deaths in all communities. When someone is given treatment in the emergency department and then referred to a outpatient procedure or maintenance program, they are more than twice as likely to follow through and continue a sustained recovery versus a referral alone. So, you know, one of the things that many people have said to me is that, you know, what do you think you'll see in the emergency department? Do you think a lot of people will be here? And I don't know that we'll see a lot of volume, but when they ask me, well, you know, all this effort and all this human power, the people power that have gone into it for one life, I respond by saying, like, that's not just one life. That's someone's brother, sister, friend, family member. And aside from roles, that's an intrinsic worth of a human being. So I think that what we're doing here is an innovation for the community, but I don't think it's a revolution. I think the revolution is in this room, and I think the revolution is when we start to think about and recognize that we are not here to hate a person, we're here to hate the disease of addiction. So thank you.
Thanks, man.
Hi, I'm Jeff Kane. I'm a medical doctor. I'm the Chief of Addictions Services at the Brattleboro Retreat. And the Retreat has been around since 1834, founded on Quaker principles of moral treatment, and we expect ourselves to treat every patient with warmth and respect. There are probably over a couple hundred patients at one time on medication for opioid dependence at the Retreat. And if there are questions about those programs, and there are also programs, intensive outpatient programs, partial hospitalization programs, and inpatient programs where people are also treated for addiction and they're not on medications. If you have questions, especially about the hub and spoke, I'll be glad to field those questions afterwards. And Gina Pierce is here. Gina, raise your hand. She's the clinical supervisor of the hub and spoke, and she'll be available also. I want to take this limited time, though, and say a few things about what we're looking at. If you've been puzzled by addiction, if people all did what's good for themselves in the community, we wouldn't have this problem. But people do things differently. I just want to talk about that for a little bit. I'll also say this. Most of what I've learned about addiction has come from the thousands and thousands of patients in the past 45 or so years who have shared their stories with me. I've also learned a thing or two from brain science, and I'll say just a little bit about that. When people develop addiction, it's like building a fire. You need the right stuff. Some people are more vulnerable to addiction because of their genetics or because they've been treated poorly. And if we reduce the people who are treated poorly, we're going to be reducing the vulnerability to addiction. In order to get started with an addictive substance, it has to be available. So I appreciate the efforts of law enforcement to get as many drugs off the street as possible, because that not only feeds new addiction, it makes it harder for people to stay in recovery from addiction if they've had the problem already. And besides vulnerability and availability, and anybody who's not especially vulnerable can develop addiction if they practice, so that's always a risk. But there need to be permissive attitudes towards substance use. And I was heartened a day or so ago when I overheard a father telling his 9-year-old son how important it is not to start using drugs and to stay away from people who might influence him to do that. Wow. There's a lot of variability when it comes to addiction. I've been dealing with people, like say, in the deep end of the pool, but if you think you might have a little problem and you're in the shallow end of the pool, don't underestimate the seriousness of it, and don't underestimate the help and attention it may take to prevent things from getting worse. Once people start to use an addictive substance, there's dopamine release, a sense of reward in the brain, or a sense of relief from pain, physical and emotional pain. That keeps people going back. They go back, and that repeated experience conditions the primitive instinctual part of the brain to use over and over again. So addiction becomes an automatic behavior. So if I'm addicted to heroin I haven't used for a couple of days, I get paid today, I go to the teller's window and cash the check. Cash like puts me on a moving sidewalk to the dealer, and I'm off and running. So I may need to go to direct deposit, not have a credit card if I want to protect myself from that automatic behavior. It's even trickier because the brain scientists tell us that someone with active addiction, they use the word salience. That kind of has to do with relative importance. The salience of more drug takes precedence over personal safety, personal health, family, and community. Picture yourself in the mid-1880s in Amherst, Massachusetts. A man who happened to be the poet Emily Dickinson's father saw a gorgeous sunset. He wanted everyone to see it, and he knew it wasn't going to last very long. He ran to the fire bell in the town and rang it and rang it and rang it till everybody got up from the supper table, came out and looked at the sunset. The salience in that experience for him was the gorgeous sunset and wanting to share it. He didn't care about disturbing people's dinners. He didn't care about breaking the rules of the fire bell use. He didn't care what the local fire chief thought. He wanted to have everybody enjoy the sunset. That kind of overpowering drive without caring about anything else, that kind of salience is what people are up against if they have an active addiction. More use, regardless of everything else. Nothing else matters. It's like holding your breath as long as you can, and then you take a breath and nothing else matters. So it's important to have that understanding and maybe compassion for people who have addiction, and also to hold them accountable for their behavior. They can't just do things that are against the law or are disrespectful in relationships. They need our understanding and acceptance. They also need accountability. As far as medication is concerned, how many people remember the pictures of Flat Street after Irene where it was just all water? What if by some additional quirk of climate, it was frozen water? Everybody who was trying to walk on it would be at risk. Picture the people falling, the people are breaking hips, cracking their heads open. What do you think we'd do as a community?
Break some ice.
How about issuing those little traction cleats so people can walk around if they need to get across the ice? Medication for addiction is like putting on something that gives your feet more traction. It can help people keep from falling down over and over again. It doesn't get them across the street. They still need to connect with people and engage in relationships with honesty and accountability to recover. And in fostering recovery, we need to help educate people that they need to keep their distance. They can't trust themselves. They also need to ask for help. I'll read one last quote. I decided this week it would help if we had honesty camps, so we could make a bigger fuss about honesty and how important that is. But this is from A. Philip Parham, who wrote meditation book for recovering persons. There is no power stronger on earth than the courage to face our past. And one of the things that hangs people up is they have trouble talking about their mistakes, owning their mistakes, and facing responsibility. And that's where the healing comes. A patient said this week, and I've known her for 10 or 15 years in and out of recovery, and now I think things are going real well. And she said, I finally got over myself. Providers need to get over themselves also and focus on the individuals that come their way. Thanks.
Thank you. My name is Chad Simmons. I work for Healthcare and Rehabilitation Services. I'm the project coordinator for the Windham County Consortium on Substance Use. A year ago, a group of folks came together and applied for some funding to figure out what's happening in Windham County around opioids and what we can do. We received that funding, and how we chose to use this opportunity was to listen to people's stories. So we've been spending the last 6 months hearing what folks' experiences have been. We've been prioritizing folks with lived experience, folks who've been impacted the most. What that means is coming from historical trauma, generational poverty, racism, and really lifting up those voices to help inform how our community can come together. So we've had 25 community forums and focus groups with a variety of folks throughout the community, including folks who are actively using substances, including teachers, first responders, service providers and professionals, folks in the recovery community. What we're finding and seeing is that these stories can help shift how we come together as a community, how our service is provided, and ultimately how our economies and systems are functioning together. And I think our goal is to work together to have a variety of voices at the table and share later this year a variety of a menu of options in which we can employ. Things that we can do now, things that can save lives now, as well as things that can build connection with one another. I'll share a quote from a sentiment that was shared with a group of folks who are actively using in our community, and this was shared amongst the group, and it was like, we just want a place to be. And I think that's something that binds us all, is like, we just want a place to be. I think that's something that resonates with us all. And there are folks in our community who don't feel like they have a place in this community. And that builds isolation, that builds disconnection, and that feeds into a lot of what we see, the hurt, the fear, and the disconnection in our community. And so I encourage us all to take those stories and to look within ourselves, and then to build connections within our institutions, in our economy, in our culture, to save people's lives now, and to build the communities that we want. I think I'll share the rest at another point and leave it at that.
Hello. I'm Rihanna Kendrick, and I'm the Director of Operations for Groundworks Collaborative. For those who aren't familiar, Groundworks Collaborative is the merged organization of what used to be the Brattleboro Area Drop-In Center and Morningside Shelter. And this June, we celebrated our 4th birthday, even though both agencies have a long-standing history in doing this work in this community. So, all right. Our programs support those in the greater Brattleboro area who are struggling with homelessness, housing insecurity, and food insecurity. The programs we operate specifically are around food, shelter, and supportive services. Our major programs are that we operate 3 shelters, and so we operate a day shelter, a year-round shelter, and a seasonal warming shelter that's open from November to May. Our shelters range in the way that we support people from low barrier to high barrier. So some of our spaces we are able to support folks who are struggling with substance use disorder, and some of our spaces we are not, because we house families with small children at the same time. The reason that we sit at this table is that over the past 4 years, our work has changed significantly as we've seen the impact of this crisis unfold in our community. 4 years ago, our biggest challenge in our seasonal warming shelter were those that were struggling with chronic alcoholism and persistent untreated mental illness. This year, as we finished up our season, our biggest concern was ensuring that none of our clients died in our space as they struggled with opioid addiction. This continues to be our largest concern and why we operate our programs with a focus on harm reduction. We aim to reduce the risk of the behaviors that folks are engaging in and to provide wraparound supports by offering services and collaborating with our community partners. We're particularly proud of Great River Terrace, which is a permanent supportive housing community on Putney Road, formerly the Lamplighter Motel, where we offer housing, supportive services, and a subsidy. We've seen great success as we finish out the first year without having a single eviction from folks who are living in that site. We continue to be a part of many conversations like this at more tables than any of our staff can count, and continue to advocate that any solution to this crisis needs to include housing as at the most basic front. If folks don't have housing and a place where they can sleep at night, the chances of them recovering from an opioid addiction is pretty slim to none. As an agency, we also believe that our community is only strongest when every person in our community is receiving the basic supports they need to survive in life.
Hello, I'm Susie Walker, and I'm the director of the Turning Point Recovery Center. If you don't know what that is, it's the big yellow house on the corner of Elm Street and Frost Street. It's a peer recovery center for people in recovery from substance use disorders. That means we're peers in recovery. We have lived experience. We can tell each other, especially newcomers, that yes, I remember when my substance use took me to a place where I couldn't keep a job, I couldn't keep a home, my relationships were broken, and I was lost, and I didn't know what to do. And I can tell you what changed for me, and it starts with a sense of connection with another human being. That's what we do at the Recovery Center, is we connect with each other, and we can understand where we've come from, and we can give people hope that people do recover. There is hope. It gets better. And I thought what I would do is just introduce you to a few of our people in recovery and tell you what they're doing in our community today. I can tell you about a young man in recovery who was resuscitated 6 times by first responders. And then through the years, I got to see this person as a volunteer, and then as a recovery coach, and then as a leader in the community, and someone now working as a partner. And now we all get to support people in recovery in a different way. But I get to see, over my tenure at Turning Point, I get to see people come from that point of desperation and loneliness and pain to being vibrant, vital members of the community. And that's what we need to remember, is that every person has that potential and that need to feel that sense of belonging and that need to have a place. And that's just one story. I can tell you about another gentleman who spent some years in prison and came back out of prison and is a vital member of the community who helps people get connected with jobs and helps people in quiet, gentle ways that people just don't know about. I can tell you about a young woman who was separated from her children for about 1.5 years due to her substance use issues, but because she could connect with a community of people who met her with compassion and without judgment, she was able to work with, she found out who to talk to and how to talk to them. And by just doing the next right thing, as people in recovery say, she, after about 1.5 years, I think, was able to be reunited with her daughters and is now just an amazing example of recovery in their life. And that can serve as an example of recovery and prevention in their family. I can tell you about people that, as I said, were homeless and that they're now, they're able to have a stable housing situation and keep a job and have this yearning to give back and a yearning to be part of. We have people who come to volunteer, and their lived experience is that they're family members who have lost someone and they don't know what to do, and so they come and ask. And what they do is they help spread the message of recovery, because recovery isn't only the person who is struggling with substances. It's their family members, their coworkers, their friends who are bewildered and don't understand what's happening, and it's frightening. I'm a person in long-term recovery, and for me that means I haven't had a drink in 21 years. And one of my turning points was when a coworker grabbed me by the shoulders and shook me and said, "Who are you and what have you done with Susie?" Because addiction robs us of our very selves, and we need the people in our community to bring us back.
Okay, thank you all. Some really great, compassionate and caring work going on in our community. So thank you all for sharing what you are doing. And we will now turn it over to question and answers. We have a lot. Yes. Are you asking a question?
I just have a statement to say very quickly.
Okay.
I used to be from here. I've lived in Ohio for 15 years. It is the epicenter of this. Springfield is 8 miles north of my town. It's the #1 city for ODs in the United States. I can tell you now that compassion is the way to the cure. Because in my state there is no good Samaritan law, and Narcan can only be given by police and EMTs, town by town, county by county. So you can live in one county and OD, in another county you're going to get services, but only from a police officer. There's nothing like this there. I came here to see what Brattleboro was doing, and I thought they're going to be doing a lot better than Ohio. But Ohio is in part having the trouble it's having because of this attitude of it's their fault. I've had students, and I'm a professor, I've had students say, oh, they OD'd 6 times and they brought back, they deserve to die. My students have said this. And I actually had a student come in from Wright State working on a master's and say, I'm one of those people. And she changed my class. She sat there and talked to them because they could see a face. But that lack of compassion is going to be your way out of this, because Ohio doesn't have it, and it's a nightmare there. I can tell you now, the programs there, they're fighting fentanyl strips, everything that makes sense, they don't want to do. So, great, good for Vermont. That's all I got to say.
Thank you. Thank you for sharing that. So we have a lot of people in the room. I'll just ask that you raise your hand. We'll call on you. The chief is going to come around with a microphone. You do have to speak in a microphone so that BCTV can hear you. So chief will come around to you, and we'll start right here.
Do we have to?
Talk in a microphone? Yes.
My name is Don, and I'm a member of the community. I live right on Elliott Street. Also been in recovery myself, and I know some of you. I've been to the retreat 14 times. I've been to the retreat 14 times. Turning Point's been instrumental in my recovery. It's a place where I found my support, reinforced my recovery. One thing that is missing in this key thing is when the addict or the alcoholic comes out of treatment, gets on medical assistance, a lot of people have burned their britches. They don't have a place to go to. The Turning Point it seems to be the only place in town where an addict alcoholic can find that support, through other recovering addicts and alcoholics. So there is one halfway house in town, and there needs to be more. Because we can get sober and clean, but the hard part is learning how to live life on life's terms. So I'm wondering if there's any discussion about setting up some short-term residential programs for these individuals. I know that housing is wonderful, but there's only so many of them, and so how do we not just catch them, but how do we keep them in recovery? That's what I have. Thank you.
Does anyone on the panel want to respond to that? Or, yeah.
Thank you for making that very important point. So I've also had the pleasure of serving on the Governor's Opioid Coordination Council, and one of the taskings that we had was to do kind of a statewide review of what we had for recovery residences. It's safe to say there's huge inequities across our state. Downtown Housing out of Barrie commissioned the report, and the goal right now is to set up 12 new recovery residences across the state within the next 18 months. And I do believe that Brattleboro was identified as a priority area. I unfortunately don't have the report with me or the particulars, but I'm happy to send that out to folks if you just want to either give me your contact information or grab my card before you leave tonight. So across the state, that is something that we're trying to pay a closer eye to, because we know housing is absolutely critical and people need to have a solid place to be, and sometimes going into traditional housing settings is not feasible for folks.
Thank you, Stephanie. Thank you. Down in the front, yeah.
Hi, I'm Cassandra Holloway, and I work with the Brattleboro Area Prevention Coalition, and I'm just seeing so many people in this room, and I do this work all the time. I'm part of the Consortium of Substance Use. I created a resource guide that's back there for people, recently updated, and I'm still learning stuff. So I want to just make this opportunity. There is a Facebook page called Community Opioid Response. I would like you to like it so we can use that to get all of this out. And also I created a Gmail account as we were here called coretalks802@gmail.com. Hopefully you guys can put that if you're doing something in the comments. Try to get on it so we can keep you on an emailing list, because there's going to be a lot happening with this. As you can tell, there already is a lot, but there's more. So yeah, let's just keep everybody in the loop, and hopefully there'll be things that all of you can do as well. Thank you.
One thing I forgot to mention in the beginning is that there is, over in the corner when you first walked in, there's just a list of the panelists and a brief summary of what each does in their organization. If you didn't get one and you want one, please let us know. We'll make sure that we make some additional copies. I'm certain we did not make enough copies. Yes, front.
So I have a question, because we've been working on several stories, and the current one can people hear me now? Yeah. Sorry about that. And so the question for people on the panel is, how in your work or with each other do you tease out the differences between individuals who are suffering from addiction from individuals who might be without a home, and or individuals who are asking for money, in Brattleboro, because we know that sometimes those things all get lumped together, and it's one of the things that we're seeking to do in our work, is to tease those things out. So I would love to hear how are you seeking to try to tease? Oh, okay.
There is no difference. They're people. And I think that's some. I think we need to be very clear about that in the community. They're people. We are people. We're part of the community. Once we start saying these people over here and these people over here, what are we doing? I think the woman, thank you for your comments earlier. We can learn from other communities that are going about that in a different way. The wrong way. So I in the stories and the conversations that we're having, if we just look at, and we're hearing from folks that people are people and we just want to belong, the conversation should just end there.
Right up front. Yep.
I was just wondering, I'm just a community member. A lot of my friends have been plagued with this disease, and it's really sad to see a lot of the people that I grew up with in this town, in this community, and what they're going through. I know that we have things in place such as the methadone and Suboxone clinics, and I understand the need and the use of that. I was just wondering where we're moving forward as far as actual detox clinics, and then the mental health treatment that goes along with that to continue to treat the trauma that has produced this horrible disease.
And Matt?
I'll talk about it, sure. So I think in both the question that was asked earlier and what you asked, I think that's an important point to talk about as far as trauma-informed care. If you're not familiar with that, please go home and Google trauma-informed care. It might change the way you think, or it might transform the way you work with someone or talk with someone. I think that we open a larger issue when we start to talk about the psychiatric care needs of this community. I think that's a bigger conversation. But again, when you look at the Venn diagram, it's just one circle. I mean, this is all co-occurring and it's all together. And so I think that that's where I would start, is looking at disparity, looking at trauma-informed care, and certainly it's conversations that we are having. And I don't know if you want to add more about that.
Just well said, Matt. I think there are complicated constellations of addiction, trauma, mental illness, medical illness. And research shows that the best results with co-occurring disorders are when people receive care that addresses all those conditions at the same time with the same providers. And I think there's movement toward people whose specialty has been mental health services and places where the specialty has been addiction treatment services to get more conversant with the rest of the package and to provide things in an integrated way. We do have a long way to go, and there has been noticeable progress in the years that I've been, part of that evolution.
Thank you. Junie?
Thank you. First of all, I want to thank everybody here tonight because it's evident we're dealing with a huge issue here. I'm a teacher. I'm a special ed teacher. I've been teaching here in Brattleboro for over 30 years. To the point where I'm starting to see kids of my former students. And my specialty is specifically working with kids with social, emotional issues. And one of the things that we are not talking about tonight, or we haven't raised yet, is the issue that in my 30 years I've seen medication being given to young kids, younger and younger kids. From the time I started working in special ed, from 3%, we're now up to 30% of the school population being given medication for anxiety, for this and for that, and for whatever. Between 11 o'clock and 1 o'clock, if you go to the nurse, it's a constant stream of kids going in for their medication for whatever reason, but it's heartbreaking. I'm hearing now stories from kids who have parents have started using medication while students and have continued become addicted to different kinds of medication because of their anxiety, because of their behaviors, because of whatever. And so I'm glad we're talking about at this level, okay, the people are not functioning in society, they're shooting up in drugs in the streets and all of that. But we need to take also a broader look at what's happening at a very early age.
I guess, yeah. It's Francine, and I've taught school for 28 years, 20 years in Brattleboro. But my concern is what are we doing? Are we educating, in what way are we educating the doctors, the medical, to not get people, to not prescribe these things that become addictive? And that's become a real problem. That's a real issue. And I'm sure that's being worked on in some way, but I'd like to know what's being done to get them to use other forms.
I'm going to have Dr. McGraw, who's not on the panel, but you all heard from in the beginning, speak to that.
we recognize it's an issue, and as I mentioned earlier, we are in an interesting paradox of needing to both prescribe these powerful pain medications and also treating opiate overdoses every day. And it's a terrible situation, no doubt. There are, as I mentioned, there are state registers to look at to assist us in our prescribing patterns. We are working with other clinicians to help them reduce the amount of opiates they're prescribing so that we can make sure that people are on the lowest possible dose that's effective for them. For the few, and I do mean few, who really need chronic opiate treatment. There are requirements for clinicians for education. When you have a medical license, there is ongoing, continuing medical education that's required. It's fairly robust in terms of numbers of hours per year. And part of that specifically is required to be education around opiate use and prescribing. So it's an ongoing issue that the medical profession recognizes and is addressing seriously.
Where did you go? Oh, there you
Just
are.
to further on Dr. McGraw's point, just anecdotally, I've worked in the emergency department since 2008, and the number of opioid prescriptions that I see getting written has dropped off dramatically. I think our doctors are fully aware that can be part of the problem, so we're actively working to not do that. And that goes with all controlled substances. Our doctors are very hesitant to prescribe those out of the emergency department.
Right in front. Oh, sorry. You want 1 second? Yes, Stephanie.
Sorry, I just wanted to piggyback on that. Looking at the statistics across the state, to what Taylor said, we are seeing statewide a decrease in the number of opioids being prescribed. We're working within New England HIDA with a National Emerging Threat Initiative and particularly a state of Vermont initiative, and that's one of the areas that we want to look at is around the prescriptions for some of our younger population and sort of what's happening as we are seeing that's been an increase. Also, as we're trying to look ahead at what may be happening with an emergence of stimulants. But I'd also add that in 2015, the state of Vermont passed prescriber guidelines for I believe that was for acute or was that acute? And then the chronic was in 2017. So as those laws have gone into place, we've continued to see that decline in the opioid prescribing, as well as dovetailing that with all of the additional prescriber education and the work of all of the medical centers.
Right here in front.
Hi there. Thank you all for being here on the panel, and I'm overwhelmed that there's so many great people here just to want to kind of talk and discuss this problem through. My name is Kimberly Diamond, and I am the parent of an adult child who nearly fatally overdosed 3 months ago. So this is a very personal conversation, and I appreciate everyone's efforts in this room. A couple things I'll say on that is that I hear all of the time inside conversations and online and in forums where people tend to say more than they might say in person. Just let them die. That is something that really needs to be erased from our vocabulary. There's never a place to say just let them die. And how many times will it take with an overdose before we just give up? You don't. And it takes as long as it takes. I was able to meet through this tragedy with our family some wonderful people in recovery that I now find I have more respect for than many people on this earth. And one of the gentlemen has overdosed 27 times. And now he is helping people to reach out of the depths of their addiction and get their lives back on track. So it takes as many times as it takes. And we have to be there when they're ready, period. And let's tonight just decide to end the debate of whether it's a choice or a disease, because I don't care what you think it is. It's a problem, and it's hurting our loved ones and people that you love and care for, whether you are a family member or a casual observer. This is about all of us trying to support our local community members and friends and loved ones. One last thing. I'm also the director of Big Brothers Big Sisters, and we have a presence here in Windham County. We are dedicating a large part of our program to supporting families and the children that are growing up in the shadows of this addiction. And we are dedicated to supporting these children, to find them mentors, and to provide support so that they are learning how to prevent themselves from following in their family's footsteps. And not only working towards prevention for the kids so that they don't grow up to become addicts, but also so that kids in our program that might not be affected don't grow up to have a stigma-related attitude towards people with addiction. So I hope that the community can come together with us in this panel to make sure that we are supporting not only the people who are suffering and are currently using, those giving the respect to the people that are suffering, respect to the people in recovery, and respect to the families that are hurting as well. Thank you so much.
Thank you. Right here in front, next to your left. Yep.
Hi, I'm Brenda Siegel, and first of all, I just want to say thank you for saying that. My nephew died, many of you know, my nephew died of a heroin overdose a little over a year ago, and he was the son of my brother who died 20 years ago of a heroin overdose. That stigma that you were just talking about, I'm just inspired to say that that stigma hurts the people who are suffering, and it hurts their families. So I do want to really piggyback on that and encourage, I wasn't even going to bring this up, but the letter that was printed in the Commons a couple of weeks ago made me feel like I'm not welcome in this town because my family members died. These are people who are suffering. And I want to ask you all to make sure that you remember that people are suffering. Because it's very challenging to be a family member. For 21 years, we didn't tell anyone in this community that my brother died of a heroin overdose because we were afraid of the stigma. We are talking about it now, and we need your compassion. I also want to address what you said about detox. One more thing actually on that. My nephew went into recovery and was in recovery for a year. He was doing really well. It was because of love and compassion. He relapsed and died because of shame and stigma that was cast at him. So I want to also add that. In terms of detox, we know that opioid use disorder is a chronic relapsing disease. For some people, they will be on medically assisted treatment for the rest of their lives, and that's okay. And for some people, they'll choose abstinence only, but actually what they're finding in the research is that the medically assisted treatment has a longer term likelihood of success. And so we don't have to be overly concerned that most people are using a life-saving medication. We can embrace it just like we would blood pressure medicine or medicine for heart disease or diabetes. We can say that this disease requires medication. So I hope that helps.
Thank you, Brenda. Chief, right here, the black sweater. Yep.
Hi, my name is Deb Whitkus. I live here in the community. I've been doing this work for a while now. I'm impacted by addiction in my own family. Susie, you know I am the biggest proponent and fan of the recovery movement. It is a movement that we all need to get behind. If we're looking for answers, I hope tomorrow morning you have volunteers at your door. I hope people are showing up with checks. I know a ton about addiction medicine. I know it takes the opioid brain 5 years to recover. You need a 5-year plan. Relapse doesn't happen because of lack of will. It's because we don't know enough about the addiction science. It takes 17 years. It's out there. We can go faster. We're smarter. I just want to say, I hope, if we really want to get answers, these people have the most powerful answers. And also, I hope there's a line outside of your door tomorrow as well. I helped break the cycle of my little through the mentorship program. And I know you need mentors. Who's gonna sign up to become a mentor? I want to see some hands. I'm serious. There are so many nonprofits who are part of the solution, and they need us to show up in real ways. Thank you.
Thank you. Right behind, Chief. Right behind.
I guess this is a question, again, incredible forum. What about safe injection sites? I mean, you know, a lot of people know me around town because I'm on my bike, and I'm a spy in a way because I hear things. You know, when a boss comes up from Bridgeport and says to somebody who everybody knows is involved in dealing, respect, man, you know, so on and so forth. We know it's a criminal activity. We also know the hospital prescribes opioids, all right? But the question is, why can't we have safe places for people to inject, that they're not getting stuff that's contaminated with fentanyl and other things and so on, that the doses can be regulated. At the same time, they can get the treatment, they can get the counseling, they can get the opportunities and so on. I mean, why don't we decriminalize the activity, make it a medical problem? It is a health problem, it is a mental health problem, it's a societal problem, but why can't we begin to move towards safe injection sites?
Anyone on the panel want to respond? Yep, Taylor.
So when we had our first responder education session, people from the Vermont State Health Department came down and they asked us directly, what kind of things do you want to see in Windham County that would be beneficial and help this issue? And one of them was safe injection sites. We talked at length about that. Another topic was, and now you see Las Vegas doing it, where they have the pre-made kits that you can get that have clean needles, chlorhexidine wipes, and then also a needle disposing kit, which I think is really ingenious. So the discussion is out there. We just haven't quite progressed or moved on along those lines, but the discussion is certainly out there.
Thank you. How about right in the front, Chief, on the left? Yep. Oh, you want to say again, Chad?
Some more responses.
Oh, sure. Sorry. Go for it.
I'll just share very briefly in our 25 plus conversations with folks, we learned one thing. People use drugs. People use drugs. And I think if we're to listen to folks from the community, I appreciate what Deb was saying, that we have a lot of folks in our community that we can hear from and learn from. People are looking for places to safely use drugs, because otherwise folks are using drugs in places that might be harmful. There's a lot of research on a variety of methods that we could use to make drug use safer. And we can connect services more effectively and efficiently. I'm really glad Matt brought up trauma-informed, because that can be plugged into how we approach safe drug use. So our community is saying we should explore these issues. Let me also say that the legality of safe use sites has come up a lot in, like, why can't we? We are discussing the legality of other substances right now in this state. And cannabis has been coming up in conversations whether or not Vermont should legalize. Cannabis would be, folks who are white, who are male, who look like me, would benefit most from the legality of that substance. And yet we still are putting a lot of negativity and stigma on those who might use other substances and say, no, that's illegal. I think we should have a conversation around that in our community, around that inequity in how we talk about substance use.
Go ahead, Dr. Kane.
And I would add that safe injection sites, other substances with abuse potential are important questions that need to be addressed, and they're tricky questions. Among the thousands of people that I've helped or witnessed, if not helped, the range of motivation varies tremendously. What people are willing or capable of doing at any given point varies tremendously. For someone who's committed, resolved to be using an intravenous substance, then a safe injection site might make sense. For someone who needs acceptance and accountability, the range of services that we've been talking about here, if that person gets those services, they might have a better life rather than settling. And the nature of addictive thinking is often to be quick to settle and not aim to the person's potential. So I worry about making it, finding the balance so that the people who are resigned and resolved to settle are kept safe and respected, but also to provide incentives for people who can do better and might if we do the right thing by them.
Anyone else on the panel? No. Okay. Yep.
All right, I'll go. Can you hear me? Okay. My name is Matt Gander, and I'm with Shanta, a reporter for The Commons, and I also lost a family member about 1.5 years ago to a fentanyl overdose, so I have a personal connection. In the stories that we've been working on since February about addiction and other related elements of Brattleboro, I've been really impressed by Brattleboro's focus on best practices and ways of coordinating. And if you do national research and you look at places like Ohio, we're in a very different place, and I'm very proud of that. Just to be a member of the community, I mean, you guys deserve enormous credit just for being here. My question is, as a reporter, is really about resources. One of the things that I keep coming back to is the question of the adequacy of resources and the way that things have operated at the national level really since the Reagan administration, and certainly with no slowing down in the 90s and with our current administration now. I wonder if any of you could just speak to what it would take, not simply in coordination and best practices, but in just funds to actually make things work so that people aren't dying in our streets.
Anyone? Taylor? Okay.
I cannot give you a dollar figure, but I
feel like it's a lot.
I feel like it's going to be a lot. Yeah. So I think until the nation comes up with a prevention campaign like they did for tobacco, I mean, everyone I knew in the early 90s smoked cigarettes, right? And now nobody smokes cigarettes. It's going to be prevention is going to be the number one thing that solves this problem. And then the second piece is going to be dealing with the people who are already suffering and getting them to people like Susie. So the two puzzle pieces of prevention and recovery are going to be I think what's going to solve it. But yeah, we need money.
Yeah, Stephanie?
So I don't have the dollar figure either, but we have, over the last several years in particular, at a national level, record amount of funding kind of across the board from treatment, recovery, housing, prevention, and I have to agree, I previously worked in prevention, and that's how we really kind of turn the tide. I think that there's a lot that we can learn from the way that we addressed the tobacco use. And, in particular, one of those methodologies was educating the youth and educating the parents through the youth. I was one of those children that just nagged on my parents to quit smoking. It did eventually work. But I think that we have had a lot more national attention to this issue. For example, at the Prescription Drug Summit down in Atlanta this year, President Trump came and spoke about the issue. We can all have differences and opinions on policy, but it has become a very bipartisan issue because it is affecting people from every political persuasion across this country. And, we still need to work on the coordination of some of that funding. It's unfortunately sometimes the announcements come out a little short deadlined, and federal applications never a breeze or a short walk in the park. So certainly I try to keep an eye on different funding programs that are coming along and put those out to partners, and we'll continue to keep an eye out for resources that may benefit, but there's never enough money to go around, and I worry about the long-term sustainability as maybe the national attention starts to wane on this, and what do we do when that money runs out, because the systems still need to be improved and people still need to be supported.
Susie?
Yes.
Go ahead.
Thank you. I can't believe I'm about to say this, because we can always use more money. We do our level best with volunteers, and we've got some small staff paid here to be working through the hospital. But, sometimes when you start talking about money, it becomes this immediate, people start thinking of, that's not going to work. And you just kind of start shutting down all the avenues that might lead you to some kind of a solution. But without money, if we can become a more compassionate community, if you think about the ways in individual families we absorb each other's pain and we help each other through things. That is something that we can do as a community, and we don't have to rely. I think sometimes there's this expectation that we'll send someone to treatment at Valley Vista or Serenity House and that they're going to be fixed. But that isn't how substance use disorders work. We convalesce, and sometimes it's a very long journey for people. And so we need to have a community that allows for that. And I think we have some maybe misguided expectations about how people are going to progress in this disease. And if we can just be more supportive and humane with each other, then that can feed the prevention work we do and the recovery work we do. And we can all be ambassadors. What we know from our own work at the center is that the more connections we make human to human, the more we tell our stories. We have peers that go to the high school and talk to the kids. And they asked for an after-school program because they wanted to have more time to talk without the risk that the bell was going to ring. So people are yearning for some of these supports. And we go to other places in the community, and we're working on doing some stories with Fish and Putney at his Fables program, and then at the Latches in September for Recovery Month, because the more people hear these personal stories of recovery, this is what happened to me, this is why it changed, and this is what my life is like now, the more we can believe and have hope and direct people to, all the wonderful supports we have here.
I want to also add that once upon a time, somebody asked me, does your checkbook reflect your values? And I think that this is something that we have to look at for ourselves personally, everybody in this room, as well as within our organizations. And we need to fund and we need to shift the funding as appropriate to the things that really matter. So at the hospital, that's meant doing things like hiring a nurse practitioner for our psychiatric patients and substance abuse patients, even though we know it's not funded, putting a lot of effort into the community health team, the hub and spoke team. We really look at that and say, this is what really matters in our community, and we need to shift our funding and our focus to that. But I think it's really everybody needing to look at their own organizations, their own companies, and their own personal checkbooks and say, does this reflect our values?
Okay, thank you all. Right, okay, yep.
Yes, my name is Carol, and first I want to commend everyone that's here and the whole community and Windham County and all those in the state of Vermont that have come together. I am so proud to call this my home and my community, and I know many of you in some capacity. I hate to play the devil's advocate, but I must do this. One thing I recall in the 80s, there was the needle exchange program. I was a part of that, and I am for that because it prevents, obviously, other diseases. But I do have to bring up the other side of that, where there are families out there that have diabetic people or people with diabetes that cannot access needles, and their families are dying because they don't have health insurance. So that I'm just bringing that up. I do recognize that as an issue. Unfortunately, that is not, that's money. That's a different issue. The other thing is, I really am very intrigued by this safe injection site. However, in a way, it makes me cringe, just like anything new. And to me, I think it's pretty new, and more research needs to go into it. And again, I thank you for having this, and I'm grateful to be a part of it.
Thank you. In the back of the room? Yep. With the white sweater. Yep. Who's been standing up, getting my attention. There you go.
I'm so grateful this is happening, and there's something that I haven't heard mentioned. When I had a daughter who was in middle school and beginning high school, I went to at least 3 programs about how to talk with my daughter and interact with her so that she would not get into drugs. And these were wonderful programs. And some of them were like one day, and we did role plays, and it was awesome. Some of them went on for months. And I just wanted to presence that because it was, I just remember being just vigilant, like every moment. And it was not an easy walk through, and it was not like a black and white thing of how to be with my daughter and all of her friends as they navigated through this. And as I was horrified, one of the mothers intercepted a text where her son was receiving a text that said, "Do you want pills or powders or this or that or the other?" I mean, there's so much out there, and we don't know what our children are being exposed to, and I think it's just getting worse. And I heard just horrifying stories, and so I think what I just want to say is that it was really helpful and supportive to have these programs for the parents, where we would be able to go and learn and do role plays and get support so that we could just be the best parents possible for our children as they navigated this whole thing. So, and I'm also, so that's one thing, and then related to that is I'm really grateful to hear that people who are recovered addicts or in recovery, that there's the ability to go into the high school, because I did hear from somebody who was not from Vermont that they were not allowed to give a presentation at the high school because the administration thought that it was too graphic to tell the students what they might be into if they go down this path. So, so that's what I wanted to share.
Thank you. Chief, right in front, the gentleman sitting with the red shirt. Yep.
One thing I want to know is that we've talked about all the touchy-feely programs going on in that, and that's good. And we have all this here, people in these various programs. But all the work that's being done, it doesn't seem to be enough. Mm-hmm. Either your programs aren't basically right, because the numbers are going up, the death rate's going up, and it's going to get worse. I just read an article in the New York Times. Fentanyl is going to be the drug of choice because it's so cheap. Heroin, it will probably go by the wayside. And one thing here, I live on Prospect Street. We got a drug house up there for a year on Central. Now, I know the police knew it was there. The neighbors counted the people daily going in and out. But yet it took almost a year to shut that place. Same thing down on Oak Street. Why does it take so long to shut these drug houses down?
So I wish there was just an easy answer that we would just go in and shut places down, but we have to abide by the same restrictions that everybody else does. People have their First Amendment rights. In order to make a good case and really shut these places down and stop the activity that's occurring, it has to be done right. So we have to utilize the agencies and services that we have, the Southern Vermont Task Force, team with the state police and other agencies, the use of federal agencies. But it's not as simple as just going and knocking on the door and running in there. We have to compile a case. You have to build a case. You have to really build that case in order to prosecute it at the highest level. So I understand people's frustrations, but we're certainly doing everything we can to hear your concerns, flood the neighborhoods with directed patrols, foot patrols, vehicle patrols, and really getting out there and intervening. But the bottom line is that we can do all the enforcement we want. Sometimes we're just displacing it from one place to the other. We need to get to the root of the actual problem. And the problem is, as you said, the abuse of fentanyl, heroin, and other drugs, crack cocaine. We have to get to the root of that problem. Otherwise, we are not going to solve anything. We're just going to prosecute some people, and as we've seen in the community, and it's just going to move to a different area or a different avenue.
Thank you. Yep, go ahead, Brianna.
As the director of many touchy-feely programs, I'm really glad that we have them because we're meeting folks where they're at, and that's super important. And I think back to the humans are humans are humans. We can't say that enough. I think also if we haven't said it enough, we do not, in terms of capacity, have enough capacity to serve all of the people who need our support. We also, as the nonprofits and agencies and hospitals and all of the folks sitting up here and many of the folks who are also sitting in this room, we are part of the solution, and we are just part of the solution. We will never solve this problem if it is on the backs of nonprofits to try to come up with the solutions. These are community problems, these are state problems, these are worldwide problems, and we have to work together to solve them.
Thank you.
Can I just add also?
Yeah.
I want to echo what Lieutenant Petlock said. It does take time. I know it's frustrating when there are drug houses. I represent the least touchy-feely program up here. And I am very thankful for the very hard work that our local, state, and federal agents do. But it is true. As soon as we shut one down, another one opens. It's like, the hydra with many heads. They'll spring up in different places. And getting to the root of the problem and adapting. What you see here in front of you is all of us adapting and changing and growing and trying to respond to the problem in different ways. And that's what we need to keep doing.
Thank you. Okay, we have time for a few more questions. How about in the back of the room there? Yep.
My name's Leo.
Oh.
I work for a state agency, and the agency.
You need a microphone.
Where's the mic?
It's coming.
Sorry, thank you. My name's Leo Schiff. I work for the Agency of Human Services for a department called Voc Rehab. And I just want to say that recovery is not only one day at a time, but it is one person at a time. And we're a state agency that's available to help anyone with a substance use difficulty who is trying to rebuild their life connected with employment. And it is a very hard road for the people who come see us, but we do have resources to help people get work and keep work and have what they need to be able to do that. And I just felt like with so many people in the room, I need folks to know that we're available and anyone with a substance use difficulty can come see us.
Thank you. Can you just pass it down, 3 people down to you? Yep. Thank you.
Hi, can you hear me? Not exactly sure. I've had so many thoughts throughout all of this. I'm going to try to put it into a question. It's wonderful to hear all that's going on the micro level in this community, working with individuals and one person at a time. I don't know if a lot of people in this room have probably read Dope Sick, which is a really great book that talks a lot about the connection between the pharmaceutical industry and the medical industry and the opioid crisis. A couple of years ago, my son had his wisdom teeth taken out, and the dentist was really pushing me to give him an opioid-based painkiller. And when I told him he could probably use an ice pack and an ibuprofen, he really looked at me as if I was just an abusive mom. And he was fine with the ice pack and the ibuprofen, and but he was very pushy with that. And I also hear people talking about the need for money for recovery and prevention. And then I look at the disconnect between how much money is being made by the pharmaceutical and the medical industry. And I also work in the school district, and I also see the number of kids that are addicted, feel that they cannot function in school without their meds, whether it's anti-anxiety or ADHD or antidepressant, as well as people my age. I think the number of my colleagues and friends are also addicted to medication, not that they're getting on the street, but that they're getting given by doctors. Mm-hmm. And I think about how much money is being made with that, and how can we channel that into, I know there's starting to be legal action with the Sackler family and some of the other companies. but how can we bring that together and have those, just to talk about that connection. Yeah.
Chad?
Yeah, briefly, I think I'll connect a little bit of that. I think it goes a little bit back to a number of things that were said by many folks in the audience tonight. Where are we putting our priorities, and how are we where are we putting dollars to match those priorities and those values? So some of the things that we've been hearing is, in addition to, I know I mentioned a lot of things around like harm reduction, safe use, but shifting our priorities and energy towards prevention, towards public investment in infrastructure. So that's come up a lot. We've talked a lot about housing, but really matching these conversations with dollars and policies that shift public investment towards public transportation, towards public housing, towards publicly investing in housing options. So I think that's really important. And to look at the full spectrum, we haven't talked about early childhood and early learning, and see that as infrastructure as well, and how important that is in terms of building from the family up and from our community up. So I'd really encourage us to, when we're talking, and myself and a number of others in the room will be coming, once we have a more fleshed out plan, to our legislators, both at the state, it's great to see so many legislators in the room tonight, both at the state, local, municipal levels. I think that we need to be talking about our municipal tax investment, or taxpayer investment as well, and what we can be doing as a community, but as well as our federal delegation, and how we shift some of our priorities at the federal level, and where some of those more systemic changes and shifts need to happen.
Here. Yep, the short sleeve shirt, yep.
Hi, my name's Larry Cassady. There's a tremendous amount of confusion swirling around the town about this issue, obviously, because of what we see in the room. There's also the issue of panhandling in the town. And part of the problem is that we're a pretty generous community. Case in point, people coming in and out of the co-op have kind of created a situation there where now people are not going into the co-op. So my question really is, and everyone's arguing about this, but when people are panhandling in the town, are we helping the addiction by giving them money, or are we not to give them money, maybe show them where the soup kitchen is, or what is the best thing that a person can do when they're approached on the street?
A list of what is available in town, print it up, make hundreds of copies, and hand it out.
Anyone on the panel want to address that?
Well, we couldn't get through an entire conversation without talking about panhandling. We get this question a lot, and there isn't really a great answer, and there's no single solution. By giving somebody money on the street, they may use it to purchase drugs. If you give them money, it is not that you are creating an addiction. Something already exists. Somebody's trying to meet their needs. Are you making it worse? It's doubtful. People are going to get their needs met in whatever way they are working to get them. I think it comes down to a bit of a personal values choice about acknowledging people and making a connection. We know that the opposite of people feeling isolated, which fuels addiction, is that we can build connections with people and acknowledge that people exist around us. I think at the same time, back to this larger issue of infrastructure, there is no place for people to go. And when there is no place for people to go, then we visibly see them in our community and in our streets. I think back to a summer ago when there was a huge push to close the wall. We've closed the wall. Now we see people outside of the co-op. We can't physically force people to go to a place that doesn't exist. And so I think as a community, we have to work on what are the solutions of where people can go.
Rihanna said some of what I was going to say, but what I would recommend when somebody approaches you on the street is that you say, hello, how are you today? what's going on for you today. And then the next time you see them on the street, you say, how did that issue resolve that you were dealing with yesterday? Because just as they sometimes might not feel human to some mainstream members of community, because of the way that we choose to show hostility and apathy, we then are not human to them either. So the bridge needs to be built both ways. So ask them their name and what they're dealing with. And if you want to give them money, do. And if you don't want to give them money, don't.
Hey everybody, I'm Fish. I've got a unique perspective on this because 5 years ago in 1 month, almost to the day, I also moderated and co-hosted a forum about opiate addiction. What I've learned tonight is this, that the problem has gotten bigger. Somebody asked about how much money is it going to cost to fix. I can tell you that there are people up here on this panel whose vocation is not to deal with opioid addiction, but they're forced into it. So the funding does exist. There is promise, there is hope. We live in a community that just births hope every single day. And this is what I've seen from 5 years ago to today, that money is coming in to help fix this problem. And then it's going to take this whole community that I see standing here in this room concerned about this problem to be just as forceful as you can be as resolving the problem. We're all going to go home tonight. We're all going to flick on the TV. We might recap a little bit about what happened. But what are you going to do when you wake up tomorrow? Are you going to stay in the fight? Or are you going to say, nah, these guys got it? And they do. They deserve a round of applause. Everybody should be clapping their hands. From our first responders that have to deal with it on a day in and day out, to all these other people who are just giving supportive services, these people just can't do this alone. So what I noticed from 5 years ago of doing this exact same forum that we're sitting here today doing it again is that if we continue to show up, we will continue to move the needle. Thank you.
Right here. The guy with the hat in the
Hi, I'm Bob, and after a number of years in recovery, I became homeless, and that put me in an interesting position. I got to do peer support with people on the streets, and that's what I do here in Brattleboro, one person at a time. There are 2 women in this town who may very well be dead very soon, and I won't mention their names, but I will give you an indication of who they might be. They're the 2 who you see with sores all over their faces. I think with the extent of how critical this situation is, maybe Brattleboro needs to make a city ordinance along the lines of the state laws, where if you know someone whose using is critical and suicidal, you can intervene, even if it's with the help of somebody like Lieutenant Petlock, even if that's what's required, because these women are close to death. One's 35, the other's about 28. As to the safe injection sites, the longest operating one, and I heard this laying in a tent in Bend, Oregon on the radio, the longest operating one in the North American continent is in Vancouver, Washington. They have drug and alcohol counselors. They distribute Narcan. They even show them how to safely inject the drugs, and they can test the drugs for the purity. And Lieutenant Petlock, as of the beginning of this week, I read on a news story that was trending on Facebook, the Narcan-resistant synthetic fentanyl had reached western Pennsylvania. Several days later, it started showing up in Massachusetts. That means soon there may be a number of people dead on the streets, and we are reaching a point where they are running out of time.
Thank you.
Well, what I can Just the best way I can answer that is, as I said, we've identified, and the people you speak of, I'm sure, are in this group, people in the community that clearly need our assistance and that need help and are at risk of dying. The only thing we can do, can I drag them to the hospital and make them get into treatment? It's just not going to happen. It's just not going to work. It's been proven that that's not going to work. What I can do is utilize the best people that we have in this fight, and it's already been mentioned today, the recovery coaches from Turning Points. I mean, these are people that have the lived experience, that have been through it, that have overdosed themselves, that have been Narcaned. They have experienced the highs and lows, and as far as I'm concerned, those are the people that are going to get through. And are we going to get through to every person every single time? No. But the point is we're trying some different things. We're getting different partners involved, and we're pushing it as best we can. And we're approaching those people as often as we can. But some people just aren't ready yet. And all you can do is put in place the life-saving measures that we've talked about today to keep people alive, and then hope that we can intervene to the point, the members of this panel and the people in the community can intervene to the point that we can get them where they need to go.
Susie, comment?
Right.
Yep.
Oops, thank you. I also wanted to say that what our coaches see in the work we do, and what they especially see when they go out with the officers with Project CARE to do outreach in the community and to follow up with people who've had overdoses, is that it often takes maybe half a dozen or 8 or 10 interactions before the person says, okay, you're for real, you care, and I will trust you. It's about relationship and connection and compassion and treating people with dignity. And some of these people have been ostracized for so long that it just takes a while for them to believe that they matter.
Thank you. Down on the end of the table, the white tank top. Yep, glasses.
Hi, my name is Ann. I'm the front-end manager at the Brattleboro Food Co-op. A lot of you probably think, oh boy, I wonder what's happening or what's coming out of her mouth next. And it's not probably going to be what you think. One of the things that has occurred to me after having an experience with a young woman who came into our restroom and told me that she was the victim of assault and robbery, and didn't want any medical attention initially, it turned out that she was experiencing a bad overdose from some type of drug that had been doctored with something else. And what I realized in that experience was, after the episode was over, one of my other staffing came through and said to me, well, of course she's an addict. And I said, well, what do you mean? And she was like, well, she had all the classic signs, and she had the spots on the face and the way that she was acting. I'm a layperson. I don't work in this community. I sell natural foods. And I realized I couldn't identify somebody who might need a different level of attention. Had I known that as soon as I saw her, we would have just called 911. But initially she told me she didn't want services called. So are there resources in this community for those of us who work with the public, like we do at the co-op? We have people coming in and using in our bathrooms. We've had multiple overdoses. I've had my staff traumatized by walking into an overdose, by walking in and somebody's bleeding profusely from the back of their head from a different kind of substance who had fallen down. And so how do we recognize some of these symptoms? Are there resources in this town for those of us?
I can answer. I have to turn my mic on. I can answer that in two parts. One, as far as identifying the signs and symptoms of somebody that's been using, there's certainly programs in place. I know that I work as a drug recognition expert through the state of Vermont, and there's a program, there's probably about 50 drug recognition experts in Vermont who our main job is to respond to impaired drivers and evaluate them and determine whether they're under the influence. But many of the people throughout the state, they'll put on trainings. They often do it at schools and various other places. Sandra, you're probably familiar with the program. But that's one way. that's one way where lay people can start to understand more of that process.
So who do I get in touch with?
You can get in touch with me. Or Cassandra, actually. And then the second part to that is part of what we wanted to do with Project CARE is develop more resources in the community and make them more available and get the word out that these are available, put pamphlets together, make ourselves at the police department available to answer questions like that. So anybody in this panel or anybody involved with these organizations can help you in pointing you to resources. There's plenty of pamphlets and literature that have all the different organizations that are available. And Turning Point is pretty much the hours that you would be open at the co-op and most businesses downtown. There is somebody there and available to answer questions and help out if you have somebody that presents at your doorstep, but the police doesn't seem like the best route or intervention.
The other thing that I have two more points that I'd like to make. The other thing I'd like to say is that while I understand the necessity of being a compassionate community, because I actually have a family member who is struggling with addiction personally, and it's affecting my family personally as we speak, what we see at the co-op is, because I think that there's probably some coexisting things going on that were talked about earlier, is that there is a distinction to me between being compassionate and being tolerant of uncivil behavior, which is happening right outside of our door, which one of the reasons, in addition to the panhandling, that people are saying they don't want to come to the co-op is they don't want their literally 92-year-old mother, who she parked away from all of the stuff that was happening on the Whetstone. She parked far away, went into the store, left her 92-year-old mother in the car, and when she came out, a man had knocked on the window and her mother had just given the man money. We've had acts of indecent exposure and sexual activity at 3 o'clock on a Saturday. And to me, it's really hard when I walk back and forth through the transportation center from Green Street and the Whetstone Pathway 10 times a week, because that's my route to and from work. And I am a compassionate person. I do say hello to people. I won't give them money, but I will buy them a meal if they want to take me up on that. So I just want to say that there is a point where our compassion for those of us who are on the front lines day after day after day becomes exhausted. But I really would like us as a community to also recognize and address the uncivil behavior that is happening publicly, and that's really affecting a lot of us that work downtown. And the last thing I would like to say is, if what I really want to come out of this meeting is I want there to be a way for me as an individual. I want to get involved. I see these people all the time. What are we going to do about this coming out of here? What kind of groups are going to get formed? And how can those of us who live and work in this town become involved so that we can help all of you who are doing this work do what is going to be necessary to be sustainable, so we don't have this conversation again 5 years from now.
I'll say one thing and then I'll shut up and move it on to somebody else across the panel. That I think everybody on this panel would agree that we have to still hold people accountable. Behavior like you mentioned cannot be tolerated, and we cannot tolerate it. And we need the people in this community to make us aware of those behaviors so that we can intervene in those situations. And as it comes to what you can do to help out, I'll let someone else speak on that so I can shut up for a little bit, but there are plenty of available options. Turning Point needs people, Groundworks needs volunteers, but I'll let somebody else speak on that.
I just mentioned that if you can go to just go to coretalks802
Thank you for saying it, because I didn't get it down.
And that's only because there isn't a place yet for people to reach out to, but that can connect you to all what's happening, but also what you can do and what's there to support you as a community. So it's kind of a quick fix, but COR, which stands for Community Opioid Response, COR Talks 802 @gmail. Or if you're on Facebook, go to Community Opioid Response and like that page, and we will use that also as a way to keep the community informed.
Thank you. So we are past our 8 o'clock. The few members of the panel that I have surveyed here said that they're happy to stay and answer a few more questions. I know people need to leave. It's been 2 hours. It's hot in here. But if there are a few more questions, then let's take them and see if we can get some responses. So how about right in the middle there with the maroon shirt? Yep. Maybe just give it 2 minutes for those that need to leave. Thank you, everyone, for coming. Those that are leaving now, thank you for being here.
I'll see you all tomorrow at Turning Point.
That's going to be the end of that.
Hey, man. I'm trying to get involved.
We would ask, though, that if you're going to leave, that you please do leave and not have your conversations in here so we can keep going. I see lots of conversations. Please, let's us get this going here.
I'll give it another minute.
I'm still seeing conversations. If you could take that outside the door, we would gratefully appreciate it so we can keep going here.
All right, all right. I don't know, it's not very exciting.
Hi, Kevin.
That worked well.
Oh, they can't because it's so loud. Okay. Okay, we're going to keep going. So if you don't want to stay, please do exit, and we'll continue on with questions for just a few more minutes, and then we need to let the panel go also. So I'd say go for it. Question. Just make sure you speak into the microphone so it's loud.
Can you hear me? Okay. My name is Audrey Garfield, and I grew up in Brattleboro, and I work around the state with people suffering from addiction under the SBIRT grant, and I also train recovery coaches around the state in motivational interviewing. Couple of things. I'm glad to hear people talking about trauma-informed care. I'm really glad to hear about that. And I also think it's impossible to separate addiction from mental health. So I hear a lot of talk about addiction, and I hear a lot of talk about mental health. But to me, it's impossible to separate those two things. So one of the things that I know is needed around the state from talking with people who struggle with addiction is when they are ready to stop using, we need beds. Often they have to wait a couple of days, even a week, sometimes more. And in that amount of time, somebody who's ready to get on top of their addiction has all that time to keep using and rethink their decision. So I know that we need more beds. I know that's a thing that we need. Also hoping that the conversation about safe injection sites continues, because I think that's going to be a critical defense in this, in getting on top of this situation. And the other thing I would like to hear people talk about is mental health urgent care.
that's something that's being done in other parts of the country. It hasn't been perfected yet, but I don't know that there's anything as perfect in this system. But I think mental health urgent care is something I would like to hear people talking about, again, in terms of addressing the addiction. And then I want to make a point about, somebody said something about people stepping up. And no, it wasn't you, Deb. It wasn't you. I heard a couple of other people talking about members, individuals stepping up and getting out their checkbooks and doing the work. And I just want to say that that's happening. We're here. People are doing that. All you people, everybody is doing that work. It's a labor of love. You're probably making about $3 an hour when you get done with how many hours you put in. Recovery coaches, volunteers. What's really frustrating is that we don't talk about the bigger issue, the fact that basic needs are commodified, people can't get housing, and CEO salaries of for-profit medical centers. That's incredibly frustrating to me. I had a very close family member who was in a local facility for mental health issues, and they had a 10-minute Skype phone call with a doctor who diagnosed them and prescribed them 2 different meds in a 10-minute Skype call. And that's protocol for that institution. So, we got to talk about these bigger issues if there's ever going to be money for us to really do what we need to do. And I would encourage people who are already getting their checkbook out to go and vote for people who will prioritize these issues and take money out of the pockets of the 1% and the corporations and put it where it needs to be. Thank you.
Other questions? Yep, right in front, second row there. Chief, yep.
Why is Windham County suffering more than the other parts of the state?
Anyone on the panel want to address that?
I'll start. I don't think that's the case. I think Vermont as a whole is suffering. I think the nation is suffering. We heard about Ohio. In the West, it's methamphetamine here, it's heroin, but this certainly isn't local to Brattleboro, and it's certainly not local to Windham County. Other places are doing different things to combat the problem. Other places have different resources that Windham County doesn't have. But I think if we weren't doing what we are doing, the rates would be much higher, I can tell you that much. And it's a nationwide problem. And some people tell me that Burlington's got it figured out. They don't have it figured out. There are things that they're doing that are working, but nowhere in Vermont has this figured out. And part of it is just where we are. It's just we're in a location that is easily accessible from different areas.
I just have to add, thank you, Audrey, for pointing out the economics. This is, economically speaking, driven at the state that it's in right now by generational poverty in rural settings. That is where the opioid epidemic it is now moving into urban settings. We cannot separate this issue from economic opportunities. And I know a ton of young Vermonters, 8 of them graduated from a high school I work with, who have absolutely no career paths, despite the fact that there are a ton of, I love you nonprofits, I do love you, but I'm going to say this. There are a ton of money going to get these kids jobs, and the connections and the collaboration, it doesn't, we've got to work better on that. And only one more thing, and I'm Susie, I'm going to do it again. We're not funding our recovery centers enough. They are doing the most important work in this state. It is evidence-based, it's peer-based, which is the most powerful approach we can use as human beings now for mental health and in recovery, and they are grossly underfunded. I work in prevention. I love prevention. Prevention and recovery together, we're talking a 2-generation approach. We get tons of money. I want the state to start giving with parity to the recovery centers. They operate on nothing. They have little or no support administratively. SAMHSA, the federal agency that gives all these grants out, actually wanted to give them a full grant for technical assistance so they can bring things to scale. And I'm just saying, I'm saying it again, you know, if we could get, prioritize what's really effective and working, what everybody else said here, the power that you have can really make a difference. And I'm not saying it's not the cure-all, but it is where we really need to be focusing. Thank you.
Thank you. Yes, Stephanie.
Those were some great points. A couple of things that I feel the need to point out. One is that while there may be disparity in some of the populations that this is impacting, it really knows no socioeconomic boundaries. We have plenty of people in our state that are from wealthy families and wealthy communities, perfect home lives growing up that are dealing with this exact same thing. So I really always try to caution people not to try to make this a low-income issue, because it's not. Second, speaking to the sort of the impact on Windham County, when we look at drug trafficking routes, being along an interstate corridor certainly does not help. But, as we look at what the ratios and the percentages of increases over prior years with our opioid fatalities last year were, sure, Chittenden County saw a 50% decrease. That's not a trend. That's 1 year. And they are doing some proactive things, just like what, Brattleboro's doing, Rutland's doing, Bennington's getting more active in a number of issues. We've got, community collaboratives cropping up all over the state to try to look at bringing together, just like with this panel, various stakeholders, because we have to work together to deal with this. And certainly Windham County is not alone with seeing an increase in overdoses. A number of counties did, Windsor County as well. Bennington County saw a 150% increase last year over the prior year. So you're not alone, unfortunately, in the battle. But as we're dealing with more and more powerful synthetic opioids, unfortunately, until we start to curb some of that demand, it's going to be a challenge.
Thank you. How about, yep. You're still on TV, so you still have to use the microphone.
Okay. So I have 2 points I'd like to make, and I hope I can remember them both. So they're actually questions. I'm hearing about the safe injection sites. This is the first time I've heard of them, and it's kind of an epiphany for me. It made me wonder how that would affect street dealing. It seems to me if there were safe injection sites, then there would be less street dealing, because people wouldn't have to buy it on the street, and it would be safer in general for the community as well as for the drug addicted community. Pardon?
You still have to buy it. It's not you wouldn't be able to purchase it at the same.
Well, maybe that's another conversation to have. Treating it like a disease, and so the medicine would be and it would be managed. And the other, maybe you can afterwards. So the other point I wanted to make was about, what was it? Was it right? I would forget. Oh, okay. So someone brought up the point of if someone is, close to endangerment of overdose, that there could be some kind of intervention, and that I was surprised to hear that there isn't already some kind of protocol for that. So maybe someone could enlighten me about that. If I know that I work with elders, and in elder care service, if an elder is endangering themselves, by neglect, living alone, they can be, you can contact an elder social worker to intervene and help them get what they need. Is there anything like that for drug addiction?
Brianna? Yeah.
So I think the context in which it came up earlier was talking about the ability to involuntarily hospitalize people, and that does exist. There are ways to do that in Vermont, and they're not simple. We're a state that supports people's free right to great lengths, and sometimes that can be really challenging for those of us working in the field and feeling like there are times where we'd really like to just help someone get enough support to get to the next step. I would say that there are states, Massachusetts is one, where people can be sectioned in a much easier manner, and there are no results in Massachusetts that show that that is an effective approach to curing problems with addiction. So I think we will continue to stick to supporting people's free right, and there is a significant amount, I think, Lieutenant Petlock was talking about Project CARE. There's a significant amount of outreach and support that goes out to folks who are struggling, and sometimes that's not enough.
Anyone else? Okay. Where are you? Yes. How about over there with the glasses on your head? Sorry.
So I can see better. This kind of segues from that question in a way. Would a drug court and/or DUI court make sense as a strategy? Part one. Part two, if so, how would you do it quickly, not after the study bill gets passed, which would be in another biennium, I would suspect, which I think there is a study bill that's in. But if it were done more quickly, even if we're cobbled together in a certain way, that there were a volunteer judge who would decide to do that. Is that a possibility? And then maybe augment that with volunteers.
I bet that
Tracy?
question is
Yeah.
directed at me. So we actually already do have a DUI court. There's a regional DUI court. I am a big supporter of the DUI court. I think it's great. The regional DUI court is challenging for me to support because it's in White River Junction, and we're talking about people who have DUI convictions and hence no license. So that's challenging. We have a few people from this county who are able to participate. They've been working on trying to get them rides, so I wish it was in Windham, but it's in Windsor and we're trying. We are trying to start a movement. I know there's a bill to have a study committee for a drug court, and the legislators and state police asked me if I support that. I said, yeah, I support a study bill, but I support a drug court more. So one of the things that we quote you on that? Yes, absolutely. One of the things that we've been trying to do in the criminal justice system is to collaborate with the public defender's office to say, if a drug court were dropped in our lap right now, how many people would we all agree upon could go there? Like, how much support is there really on the ground? And we actually just finished that project between the public defender's office and my office, and we came up with 21 people. Now, that might not sound like a lot, but when I tell you there's 2 people in the DUI court that's regional, it is a lot. And that's just my office and the public defender's office. So we're trying to nudge the people who hold the decision-making powers about where these courts should be towards looking at Windham. But the move right now, and I could stand corrected, I guess Molly's still here, Emily's still here. I understand the movement in the legislature is a little more towards regional treatment courts, which is, is something.
Thank you. In the back there with the green shirt. Yep. We're going to do 2 more questions, so this is 1.
Hi, my name is Brett. I wanted to just ask a question about something Dr. Kane said. I think that I get confused about how do you said something about compassion, which I think we all know we need, but you said accountability. And how do you hold someone accountable with this salient, how did you describe that? This salient, how do you hold someone accountable who's thinking in that, operating from that place? And the other thing I thought about, it's like in the old days it was just say no, but maybe like a comprehensive curriculum for kids that talked about how the brain works and how it reacts with different types of chemicals. And so I'm just curious your thoughts on accountability with someone who's functioning with a thought process that way, you know?
I'll try to be efficient about this, but choice, that word was spoken a couple of times. When someone is in the throes of active addiction, choice kind of doesn't happen, and maybe the salience of the drug is so strong that that's the choice if there's a choice made. And people in the throes of active addiction often benefit if they're taken out of range where they have access to the substance. Now, they may need to have enough of the wind knocked out of them that they ask for help and go into treatment voluntarily, and then stay there. I've said for a long time, I don't care much why people come into treatment, whether it's family pressure or legal pressure or a medical problem. I just seek to facilitate that they find their own good reasons to persist in a path of recovery that may keep them out of circulation for a while, for whatever length of time, until they can have more freedom in their lives. A man told me once that it all comes down to your choices. The trouble is, when he was actively addicted to, in his case, alcohol, it was his friends who brought him to the hospital, and he agreed to admission. And then as he pursued recovery more, and he was in a supportive setting, having peers and professionals help him to find his own motivation to continue, that he began to have more discretion over those choices.
Thank you. Here with the blue sweater, or blue shirt, sorry.
Hi, my name is Cheryl Sprague. I was born and raised in Brattleboro, moved away for many years, and have chosen to retire back to this community. I'm a certified prevention specialist. In the last 20 years of my life, I've managed the prevention department for a behavioral health organization in central Connecticut. My question and my concern is, why wasn't Cassandra part of the panel? Why wasn't prevention front and center? My perception, and this is merely my perception, is that prevention was an afterthought. Prevention was referred to. But dollar for dollar, prevention and early intervention is where you're going to get the best bang for your buck. If you start working with kids with the adverse child experiences, studying with the ACEs study, who needs those early interventions? Those children, those adolescents are at much greater risk for early substance abuse and mental health disorders. We need to educate families. I have a granddaughter in the school system, and it doesn't appear that she's received any substance abuse education. I have a daughter that works in the school system. She's not aware of anything that's going on. And so prevention is my concern. Why is it not front and center?
Thank you so much. I can respond to COSU. The consortium is looking at this from a spectrum. So prevention, harm reduction, treatment, recovery. I think what Deb mentioned earlier is probably an apt analogy. It's not about looking at things in silos. It's about looking at things. So a goal would be to bake prevention into all of these approaches, and all of these frameworks need to include prevention strategies. And why we might not use the term prevention, trauma-informed care and approaches are absolutely prevention. As Deb was mentioning earlier, multi-generational approaches are absolutely prevention. So these things are being baked into what the approaches that we're looking at and what we're hearing from the community. And I think it's helpful to hear a lot of the school-based programs and the concern and questions around if we have those in our schools. That's helpful to know.
Okay, we're going to draw to a close here. Thank you all. We've heard it a million times tonight, but I'll reiterate that it takes the community to all make a difference here. So please continue to care. Thank you to our panelists. You were wonderful. You have a lot of great information to share. You've done a lot of great work. So thank you, everyone, for being here. Have a safe night.